So I'm Ian Armstrong and I am a consultant physicist at Manchester University NHS Foundation Trust in the Nuclear Medicine Department. I've worked there for getting on for about 19 years now. Very varied job that I've done over the years. For the past 9 years I've been involved with the BNMS, sitting on the Scientific and Education Committee, and I've served the past 2 years I've been doing that. I've served as the scientific co-chair with my 2 other colleagues, and I will be going into, after this Glasgow meeting, I'll be going into my final year in that role, where we'll be preparing for the 60th celebrations next year in Manchester. So, I did a physics degree at Manchester. I'm basically Manchester born and bred from a career point of view. So I didn't really know what I was going to do when I went to university. I thought I'll go to university, do physics, and hopefully I'll get some kind of interesting job out of the end of it. And I think it was in about the 3rd year of my undergraduate, we did a module on uses of radiation and sort of practical applications of it. And we had some lectures from one of the academics about nuclear medicine. You know, at the time I didn't know what I was looking at. We were looking at renograms and bone scans, and I was talking about the elutions and the radiopharmaceuticals and labelling things, and I thought, well, that sounds quite interesting. So I did a little bit of digging around, and then I actually, in my 4th year, ended up doing my sort of final master's project was looking at developing targetry on the cyclotron for for generating F-18, so that was really good. And then from that point onwards, I thought, right, yeah, this is probably a career path for me. So I went and did the traditional IPEM training scheme all way back in about 2005. And then we did 3 placements: nuclear medicine, radiotherapy, radiation protection were the ones that I chose. And I think what really struck out to me was that no 2 days are the same in nuclear medicine. I feel like some of the other career options you may be a little bit pigeonholed and, you know, doing the same thing every single day. So I certainly, what struck me was that I thought, yeah, this is very varied. It's you work with certainly when I went into my placements at Manchester, it was very apparent that you were very closely involved on a sort of cross-professional group and disciplinary team, and I just found it fascinating. And so that was it. I just thought, yeah, and I pursued it, and I'm so glad that I did. I've really enjoyed it. I think, first of all, I mean, the BNMS is it's a friendly, welcoming and inclusive society, and it really tries to tend to and address the needs and the challenges of all of the cross disciplines that we have in our field, and you know, it's very responsive in issuing guidance to when we have issues like radioisotope shortages and tracer shortages and pharmaceutical shortages, things like that. That it's there issuing guidance and guiding our way through the field. And I think also it puts on great educational events and has done for so many years for the field. And again, I keep harping on about it, but it's something I'm very passionate about, is making sure that every single professional group is addressed and catered for. And I think that's what it does really well. And yeah, that's why it is and continues to be a success. My career, one of my key interests over my career has been making use of, exploiting and utilising the very latest developments in imaging technology, whether it be SPECT-CT, PET-CT, anything like that. So, you know, we were lucky in Manchester to have one of the very early solid-state PET-CT systems, and we have really sort of evaluated and optimised that imaging process to really get the best thing out of our patients. So that's always been one of my key focuses in my role in nuclear medicine. And I think for me, it's the next step, which, I mean, it's not, you know, it's here now, but I think is the total body PET. We are now, certainly in the UK, on the cusp of really starting to understand and realise what that is going to deliver over the next few years for patient care, but also just general knowledge. For us, I think we are we're going to uncover things that we didn't know. These, the very, very low tracer imaging. We can just image normal volunteers. We can image pregnant patients, for example. The fact that we are capturing all of this information over the entire body, we can do multi-organ analysis, look at relationships between the heart, the guts, the brain, all of that kind of thing. And I think we are really on a turning point of a massive new amount of knowledge to be gained for our field, which is going to inevitably benefit the patient's population. Well, I'm sure everyone would obviously say technetium, but I mean, that's too easy. So for me, I think, again, marginally, a slightly unique position to what I have in Manchester, and also what's kept my interest going certainly for the past 10, 12 years has been rubidium 82, myocardial perfusion PET tracer that we use. And yeah, it's a fantastic isotope. It's very short-lived. The patient, the doses are very low. You get fantastic image quality, but also the fact that with what we've done, in our department is we've been involved in several collaborations on rubidium with technological advances and things like that. So it's been a great source of innovation and work and developments, certainly in Manchester. So I think that's what I would pick out personally. I've talked a lot about PET. I do have a very strong interest in PET, and people that know me will know that I'm a big advocate of time of flight PET. So I suppose we should take it back to those old papers, those old theoretical papers on what time of flight brings you, the signal to noise gains in images, which is what's allowed us to get the best image quality. And they're nearly as old as me, which is not giving too much away. But yeah, so that would be, and I don't know how to express it other than in words, the signal to noise gains that we see in our images are the equal or proportional to the square root of the object diameter or the patient diameter, divided by the positional uncertainty of the positron-electron annihilation that are released from the tracers. Challenge everything. This is the way, this has always been, people will know me, and I don't often accept something as fact until I've seen it and done it myself. So it is not just to accept the status quo, it is to, I've always sort of thought about, can we do this better? What, from a techniques point of view, from an instrumentation point of view, can we do to take this forward? And that's been a key focus of mine over my years in Manchester. And I'd like to think that some of the work that we've done has really had a positive impact on the patient. So that's my, and people will say other things, but I think if I was to try and sort of say something, to follow on something that I've had a key interest in, that would be my advice.